So, a very good morning to everyone, and thank you for joining us at this morning's breakfast forum entitled Should Healthcare Workers with HIV Be Allowed to Work? And I'm Pui Li, I'm one of the infectious diseases consultants at UMMC, and I'll be moderating today's session. So, today's forum is actually in conjunction with World AIDS Day. And the theme for this year's World AIDS Day is End Inequalities, End AIDS, and End Pandemics. And the reason this theme was chosen for this year is actually to highlight to leaders the need to actually tackle inequalities. If not, there will be millions of deaths to come in the coming years. So with that, we hope that today's conversation about whether healthcare workers with HIV should be allowed to work, we'll be able to highlight some of the issues about inequalities and also start a conversation about possible solutions. Currently, worldwide, according to World Health Organization figures, there is about 37.8 million people living with HIV, and in 2020, there were 1.5 million new diagnoses of HIV. And only 73% of people living with HIV are on antiretroviral therapy. So we still have a way to go with ending AIDS and also ending the pandemic. So with that introduction, I would like to welcome and introduce our amazing panelists for today. On my left here, I have Professor Dr. Raja Iskandar Azwa, who is a consultant in infectious diseases and the clinical lead for HIV services. I also have Professor Dr. Victor Ho, who is Head of Occupational and Public Health under the Department of Social and Preventive Medicine. On my right, I have Matron Puan Hasimah Zainol, who is the Chief Nursing Officer at the Department of Nursing of UMMC. To her right, we have also Professor Dr. Ong Teng Aik, President of the Malaysian Urological Association and Head of the Department of Surgery at UMMC. So I'd just like to say good morning and thank you for agreeing to be part of this panel this morning. So to start off the conversation, I think one of the challenges and one of the most difficult things that most of us face here would be if a colleague or a friend that works in a hospital confides in us that they are HIV positive and what we should then do after. And maybe to start us off with this forum, I'll aim my question at my first question at Prof. Iskandar. So, Prof. Iskandar, do you think you could share with us what goes on in a healthcare worker's head when they are first diagnosed with HIV positive?
Morning, everyone, and happy World AIDS Day. I'm going to try and continue talking to the mask, but at times I may have to take it off, maybe just to breathe a bit better. So I think with anybody who's diagnosed with HIV, whether it's a healthcare worker or otherwise, the same thought processes and concerns often go through their head. That's fear of health, fear of disclosure, fear of intimacy with a partner, fear of transmission, of possible transmission of HIV, fear of stigma is a big thing. And you need to remember we're 40 years on in the HIV epidemic, and yet it's we're still, a lot of the issues that surround HIV disclosure are mainly issues around HIV stigma and discrimination, and the policies that affect disclosure, and also including that of HIV positive healthcare workers. Now, when it comes to specifically around HIV positive healthcare workers, there is, of course, that loss of livelihood and income and potential employment, especially if they are employed in a specialty where potentially there's it involves exposure-prone procedures, or in keeping with most previous guidelines. And so, HIV positive healthcare workers have everything to lose in terms of disclosure. And so you got to ask the questions in an environment where disclosure does not really benefit the healthcare worker and the risk of transmission is thought to be low or is known to be low. Is there a role for disclosure in those settings despite policies in place Of course, there is the need to protect patients, and that's imperative and a priority. But those have to be also safeguarding the rights, the confidentiality of the HIV positive healthcare worker. So I think so really these are some of the issues, but including loss of income, loss of livelihood, particularly affect healthcare workers. They're not unique to healthcare workers. I mean, of course, we see it in terms of the number of cases that were reported to Malaysian AIDS Council this year, in terms of cases where there was potential loss of employment. The majority of complaints or incidents came from the health sector, followed by education. So these are areas which certainly can be improved upon.
Thank you. And just going on what you were saying about, the benefits of disclosure versus the policies that are around. So as an ID physician, I suppose most HIV positive healthcare workers come to us for advice and look to us, as to what to do in the current circumstances. So, what are your current practices, or what's happening on the ground when they approach you?
Yeah. So if you think of healthcare practice in the form of a client-based practice, so we are really there for our clients and our patients, and their health, their confidentiality is a priority to us. So I think a lot of the policies in place, some of the policies are non-existing. So a lot of hospital policies don't have policies around management of healthcare workers with bloodborne viruses. I mean, that's what's the reality of it as well. And the MMC guidelines were only updated fairly recently to bring the evidence in par with what we know about the risk of transmission in the setting of a patient taking HIV treatment and undetectable viral load. And by that, I mean the amount of virus which is present in the blood that can be measured by an assay is found to be below a certain amount where it's deemed to not be detected by the assay. So, I think in many instances, we are encouraged or obliged to report a HIV positive healthcare worker to MMC, where you are confident that the risk of transmission to the partners is low. You could question what the benefits of reporting would be, right? So the reality of that is we encourage disclosure, but I'm talking only personally what's been happening with me. We encourage disclosure, and that is brought up at every visit to MMC. Generally, they are advised to report to a supervisor. We really should get occupational health involved more often. We haven't in the past, but this is something we should be looking towards because they should technically, we should be overseeing policies and guidelines around this. But in reality, where the risk of transmission, where we can get the patient on treatment as quickly as possible and get them to maintain an undetectable viral load, we try not to. We don't intervene too much. We have often what we do is we see patients from other hospitals, so we don't see patients within our hospital setting. So it doesn't really affect our hospital, but we can get into trouble, and we can potentially get in trouble, and this risks not only our reputation but our career damage. So the new updated guidelines, which were updated in October of 2020. Take more into account this new evidence base. They're protecting the healthcare worker in light with newer evidence, and it promotes an environment which encourages disclosure a bit more than previous guidelines.
Thank you for sharing that with us. I think it's really enlightening to know about real world circumstances that even though disclosure is encouraged, we still need to ensure that the policies that are around are able to safeguard the healthcare workers as well. So maybe I'll direct my next question to Puan Hasimah. Prof. Iskandar, can you turn off
Sorry.
your microphone? Thank you. So, Major Hasimah, so during this pandemic, we've really seen, our nurses and PPKs being the backbone of our hospital. They make up majority of the workforce in our hospital. And I was just wondering whether you could share with us maybe some of your experiences, if some of the nurses or PPKs have been diagnosed with HIV positive, and what has been happening with them in these current circumstances. Thank you.
Thank you, Dr. Pili. And Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all. Happy World AIDS Day today to everyone. And I would like a nursing perspective that I have experienced, because previously when I've been appointed as the Chief Nursing Officer, that I've bring about the legacy of previous administration that we tend to disclose, we tend to confine the information that how many staff that have diagnosed with HIV, whether it's nurses or healthcare assistants. And most of the staff, we will place them in a non-clinical area, and there's a certain place that we put them. So it causes a little bit of stigma, even though some of our staff doesn't know, but they can predict this is the place for a person who have some sort of disease which cannot work in the clinical area. So when we have that stigma, so some of the staff, when they want to go for higher position, let's say, so there's some certain stigma saying that, oh, they have limited tasks, so they cannot work in the clinical area. Why are they being appointed to a higher position? So that comes some sorts of discrimination. So I bring all this, I say, some sort of legacy that we need to change. During my duty as a Chief Nursing Officer, there are certain staff who come forward with a diagnosis of HIV. They tend to disclose because they want certain support and they expect a positive reaction from the nursing department. And some, I think, they don't disclose it and they confine to themselves because they are afraid of being reassigned of these and being taken out from the clinical area, and maybe some negative reactions from the peers and also in the department itself. So I think these guidelines can be very helpful for the nursing staff and also the healthcare assistants, so that we can manage better all the staff which is diagnosed with HIV, so we can help them better to support them.
Thank you so much for sharing that, and being honest with what's going on in the past, but hopefully we'll be able to make changes for the future. I was just wondering whether obviously we try to safeguard staff's confidentiality, but as you said, the practices may not be able to safeguard the confidentiality. In fact, it labels them. But has there been any experiences where staff decide to quit their jobs because of these circumstances?
So far, I didn't see any staff who quit the job because of the status. Only that they didn't seek treatment in our hospitals. They go outside, which sometimes we don't know. We can help them and support them if they get their treatment here, so that we can help them in their treatment and we can support better. So that's but no one resign.
Okay, great. Thank you very much. And maybe I can extend this question to Prof. Ong as well. So what are your thoughts if a surgeon were to be diagnosed with HIV? Would this be any different from the other healthcare workers, whether it's a medical doctor or nurses or healthcare assistants?
Okay. Yeah, thanks a lot. Thanks, Willie, and happy World AIDS Days to everyone. Thanks to Prof. Iskandar for inviting me. He called me last week, kan? Last week he called me, and then Pui Li also. I say okay lah, because why? Because I do not know the answer at that time. When Iskandar called me, I also do not know the answer, and even though so apa ketua jabatan surgery pun tak tahu jawapan juga. So it's a good opportunity for me to learn. So, but when I take that task, I remember World AIDS Day is a big thing. I was a medical student many years ago, 1992, 93, those days, 20 years ago. We also take part in the AIDS awareness and all that, and I went to campaign in Dataran Merdeka also, myself, and then I remember Prof. Puan orthopedic pun sekali lah, the same class. We went to Dataran Merdeka in middle of the night to have that campaign for AIDS awareness lah. So back to the question, can a healthcare provider, specifically for me, kalau a surgeon involved in this procedure, whether they can be safe lah, be allowed to practice. So, for me, the answer, I'm not sure lah. At that time, last week, I'm not sure. This week, now lah, 1st of December, I roughly have an idea. After 1 week, after 1 week, yeah. Because I baru ketua jabatan one year old ni, so I give a lot of excuses lah. I ketua jabatan 1 year ni, tak cukup masa untuk tahu. So far, no, of course, no staff lah. I do not know. No staff inform me that they have this disease. Either this confidential information that they do not disclose, or memang the surgeon in Malaysia, they are self-selected. If they are, they have a certain blood-borne disease, viral disease, they might self-select. They will not accept me lah. I will not apply to be a surgeon. So maybe that might be the situation. But I got a few interesting facts lah. Interesting fact. I think I will share. You got time, kan? Yeah. Okay. So this morning, every Wednesday morning, kita ada round lah in the urology team about all the consultants, specialists, HOMO. We go through Zoom because we follow SOP. We go to Zoom. So 15, 20 people will log into Zoom. We go through all the cases in the ward, and then have some CME lah. I asked them, this morning I'm going to give a talk. Why don't we poll? Do a poll, undi lah. My question is, can a young doctor, with HIV lah, the topic of discussion today, take up surgical training, enter to master and train to become a surgeon, whichever surgeon lah. One is yes. Number 2 is no. Number 3, you work, I don't know. Tak tahu lah. Okay, the poll, the senior doctor, the consultant, specialist, and senior MO, the voting, yes, 44% say yes. Sure, can, they can do. The ones say no, 33%. 1/3, they have a clear answer, they say no, cannot. And then I don't know, 22%, 22% no. Then another poll, actually, today is the 1st of December. We got new houseman, new MO, join. They got another platform. They belum masuk dalam the big WhatsApp group. So that one, the young doctor, the one say yes is 38%. Almost 40% say yes, can. The one clear said cannot. Again, same, 38%. So 40% say yes, 40% say no, and then 20% say I don't know lah. So that is the straw poll lah, simple poll from the department, my unit lah. For that ada poll. Thanks for putting up the poll. Nanti kita boleh poll. So for that then last week after Iskandar posted me this topic, I done an international survey lah, unofficial international survey. Kawan-kawan international throughout the world. So I sent out to 14 country or regions lah, depend on the political affiliation, or they come sometimes sensitive lah to cakap country or whatever. So to 14 different country or regions, I wish I got the response from 14. You can see a very clear trend. So the answer is more or less like the poll result I have in my own department. Okay, I named the country lah. Asian first. Asian got one trend, man. Western country, another type of response. Very clear cut until today. Okay, the Asian country that I survey, I just name lah. The response I kumpul sekali lah, so that we will not discriminate against the country. Nanti
Well
the
done.
embassy complain, no, ngapa cakap country saya cakap macam tu, cannot. So the country that I survey, Singapore, Thailand, Philippines, Indonesia, Vietnam, Taiwan, China, India, Hong Kong. These are the Asian country that I survey lah. Region. Yeah. Okay. The embassy will come after me. Yeah. All right. Jokes aside. Yeah. So the most surprising, almost 90% of them are very surprised that I asked the question. Meaning they do not know the answer lah. They said this is a tricky question. Tricky question. Some say it's a challenging question. Meaning tak tahu jawapan lah. One more even better. This is a strange question. Dia kata pelik mengapa you tanya soalan macam tu? Dia pelik. You see. So basically, in summary, most of them have never. They say they never think of this one. They never think. These are the senior urologists, from the many Asian countries. They will say, it's we do not know. Some actually say we prohibit unofficially say you got HIV, you better don't be a urologist lah. You don't take part. Some say officially they can, but privately they will try to talk to them and discourage. These are even very well developed economy in Asia country as well. They said some wrote to me from very developed Asian country saying cannot be procedurist. There's such a term. Procedurist, meaning you buat procedure punya surgeon lah. They don't encourage. You see, or apa OGTS ke, buat cardio ke, cannot. No specific rule, but definitely not for open surgery. Cannot. That's what it says.
I'm so glad you asked.
So and then some even said, wrote it to me. We prohibit them from becoming a urologist. Tak boleh. So this is the Asian one. Okay. And then okay. Then only Asian, only one region give me clear-cut answer. Say yes. Tak ada extra payah explanation apa. They say yes, can. And that is from Asian. That is Hong Kong. Hong Kong replied to me, a very senior urologist, saying yes, can, no ban. Full stop. WhatsApp. my method is to WhatsApp and email lah. Then we come to the Western world. I survey US, United States, UK, France, Switzerland, and Netherlands. So Europe and America. So for Europe, one from Netherlands said, I don't know, They don't know. I'm surprised. Very senior people. And then one very senior also from Switzerland also said, I'm not sure whether got guideline or not. Senior, So I feel lega sikit lah. I tak tahu pun okay lah. And then I survey France. France very, very clear cut. No restriction, meaning can. France said your personal medical information is confidential to you. Tak payah declare. That's what they say. They said they are more worried about psychological problem. If the doctor has psychological problem, they are more scared. That one maybe kena investigate. The rest all confidential. So that's what. And then UK, of course, if you search the internet, they have guideline. I think more than 10 years ago, they updated every 5-10 years. If you search, you will know the answer for UK. But the two I asked cannot also give me immediate answer. Meaning they also don't know. Even though the guideline is there. In UK itself, actually you search, they have one. So one from London, check, it said, let me say in the UK, one in London said they should declare to their, or authority or whatever, maybe the limit their scope lah. And then follow the GMC recommendation. Same one I asked from Edinburgh, Scotland. Same answer lah. Okay, that's and then from USA is the interesting one. USA is almost in line with France lah. They say okay. So they give me very good answer. one from the East Coast of US, one from the West Coast of US. They say it's a discrimination if you say the person cannot practice. And then one even give me all the references. American College of Surgeon, they have this kind of guideline, all that. And then they say one wrote there, Congress, the US Congress, extended civil right protection to HIV infected individual, as well as other with disability, with the passage of the American with Disability Act of 1990. So they have act to protect the people. So in summary, this is a survey. Only one question. The poll just now. Later maybe we share the poll result.
Yeah.
So survey via WhatsApp, email. The limitation is only urologists. So maybe urologists like me, we do not know. One question. So we total of 14 region or country, 9 from Asia, 5 from Western countries. So it seems that the response from Western country more positive. Most of them know. Some actually do not know. The US and France, they say it's okay to go ahead. The Asian majority say they're not sure, or they will say they limit the scope of practice. So that is the survey result that I have, and I would like to share today.
That's fantastic. So Sham has kindly put up this poll for us. Can a young doctor with HIV work and take up surgical training? So as you have said, 38% said yes, 34% said no, and 28% said I don't know. So it's actually quite similar to your department poll. So but I'm glad that you've actually asked this question to people around the world, and the fact that we've asked it in our forum as well, because this definitely means that we need to talk about this a lot more, and also maybe start really attacking the policies that we have to make sure this happens. So thank you for putting out the poll, and thank you for doing the poll. I guess I have one follow-up question to you. After doing the poll and finding out what everyone thinks, if someone came up to you today, one of your trainees, let's say, and said they were HIV positive, what do you think you would do?
Yeah, I think this is a pertinent question to today. I can use all the poll result to confabulate, turn around, and avoid answering that question. But it comes to me, say tomorrow after this talk, this thing happened to me as Ketua Jabatan, or like Puan Hasimah, Ketua Nursing, come to us and what should we do? If you are the boss, what should you do? So this is an important thing that we should know. I think we have to follow a guideline. If there's a guideline or guidance to us, apparently there is. Later the expert will, Pui Li, Iskandar, and Victor can showcase. Is there any guideline for us to follow? But personally, I think yes. They can practice. I probably will agree with the opinion from US, my colleague in US and France, saying that they can. Because nowadays, the two factors. Number one is that the treatment now is very good. The experts, they are treating HIV and very well with ART. That ART treatment, right? They can actually suppress the viral load to be very low and almost undetectable level. So they're actually okay to practice. And then based on the result, of course, like most of us, I search up to date. Anything you touch sure, you type up to date. How is the transmission from healthcare provider, the doctor, to the patient? Actually very low. Very low. I think I have it in front of me. Large scale look back investigation, I quote from up to date. I actually got three cases, meaning 3 surgeons, infected 8 patients in the published reported literature all this year. Only 8 infection. The first one is from a dentist, American dentist, to the patient and all. So the risk from CDC estimate the risk of transmission to healthcare provider, the patient, is 1 in 2.4 million to 1 in 24 million. There's small risk is there. That's why a guidance, a national guidance, a guideline will be important, and then we should follow the guideline if it's available. But personally, I think after reading all this, the evidence and the guideline, I would think they should. But that's of course my personal opinion. But we have to follow the guideline. That's my overall thing. Thanks.
Right. Yes, I think it's really important that people in leadership positions actually are able to say yes to this question, because everyone looks to positions of leadership here. And if your leader is going to say no, then it's almost like there's no hope for them, I guess. I would like to direct my next question to Prof. Victor, following on from actually what Prof. Ong has been mentioning. So he's mentioned a lot about his opinion, but also about the need for guidelines. So I was just wondering, what is our current occupational health standing on this matter?
Thank you very much, Wong Pui Li. Basically, the Department of Occupational Safety and Health, which is our key department looking at the safety and health of the country. So they act because there's a Occupational Safety and Health Act 1994, where basically that's what gives them the authority lah. So, and in 2001 itself, they come up with a code of practice of HIV and AIDS in the workplace, and there is basically a statement that non-judgmental, non-discriminatory employment practices. So basically, they say that you should have non-judgmental and non-discriminatory employment practices. So that is already there. But of course, the reality is different. But the code of practice. No, code of practice means that it is just below regulation, which is basically is almost like law, because it's come out from DOSH itself, and it come out under the Occupational Safety and Health Act. So there's also the another guide on that statement is confidentiality and privacy. So all these things is already there in the act itself. But of course, we continue to discriminate, we continue to be judgmental, and that is basically something that we ourselves are practicing. You look at like just now, Prof. Ong basically said that we can allow surgeon to HIV positive candidates to apply to become surgeon, but who's going to pay? There's no scholarship for anyone HIV positive. Once you're HIV positive, then there's no scholarship currently. Government doesn't support scholarship. That is what the policy actually says there. So who's going to pay? So that is what we need to look at it. So should we basically stop them from practicing their what? Is it that is something that we need to know. But it's more important. It's not about having HIV or having other infectious disease. We know that HIV is just one of the infectious diseases, but there are many other infectious diseases which is much more infectious than compared to HIV itself. Of course, we have hepatitis, which is basically much more infectious. This one we know since I think 40 years ago already. We are not worried about that. That doesn't come out. If you're HPV, HCV, that doesn't really work. And people look at you, people sympathize with you. Correct? Once you get HPV and HCV, people sympathize with you. But if you look at the other way around, HIV, people stigmatize why you get HIV. So what is the discrimination about? Is this because that it used to be because of your risk-taking behavior, or is it your risk-taking behavior that actually leads to that? So the idea is whether you can work or can work. Firstly, that should the government or the guideline says there's no judgmental and no discriminatory policy. And I, as an occupational safety health practitioner, I agree with that. I agree that everybody should be given a chance to work, and everybody should be allowed to work, because work is basically part of what makes you a person, especially when you're in this current situation in the current world where everybody needs to work. So work is basically give you that you feel that you're worthy of what you're doing. So work is correct, but the thing is that we also need to look at it from evidence based. And Prof. Ong presented a very good evidence, which is basically millions, and then only got 1 or 2 cases. And you look at it further, you dive deeply to those 2 cases or 3 cases. Those are people that are not. They are most probably they did not practice the correct practice. Basically, they are not following the guideline, or they are endangering their patient without knowing it. But if you follow practice, if you follow risk assessment practice, like, okay, I would do what you call that HIV level or in the body, right? Maybe twice yearly or yearly itself. And if I've got any problem, if it's high, of course I will stop practice for a while. But I take treatment, I would become lower, non-detectable. I can continue to practice. So there is this thing that is risk-based. Everything must be based on risk assessment, and that is important that we need to look at it. But I think the code of practice from Tosh actually says that non-judgmental and non-discriminating employment practices, and it has been there since 2001.
Thank you very much for sharing that. No doubt there's the code of practice by DOSH, which is a national document, isn't it? I was just wondering, is there anything within UMMC or as a guideline or policy that touches on these matters?
Currently, there's no specific guideline or HIV yet on whether they can practice or not. I think Prof. Hasimah would basically attest to that they're basically going to develop that based on the new document that come out from MMC. Because I think currently a lot of people don't want to take the lead and is not confident that what they do is correct now, because there are a lot of implications to that itself. The idea is that not to say that we know that we are not. We know that actually the risk for them to transmit HIV to someone else is very, very low. But the other issue that we need to look at it is also the insurance on the system itself. Whether the insurance is going to pay or not when this happens, and you knowingly increase the risk of the patient, although the risk is very, very small. But that is of course an argument that we need to do. So that got to come from the policy, the government policy that the insurance shouldn't discriminate on that issue also. Then it would be because at the end it's about money.
I agree.
Any business is about money.
Yeah.
And if I say that, because we know the risk is very low, but at the end, if the insurance doesn't cover the risk, then it becomes a problem. So
that's another fight for us.
Yes, that's basically. So MMC might have the policy, but in private practice, MMC doesn't rule. Insurance company rules, because if at the end of the day, there's money on their side. Thank you.
Thanks for sharing that. So thank you so much for all of you for sharing your experiences and what's actually happening on the ground when it comes to HIV positive healthcare workers at the moment. And actually, a few of the panelists have already alluded to the fact that the MMC has actually come up with a new guidance in October of 2020 about how healthcare workers who are HIV positive can safely practice in healthcare, and it does range from whether someone is not yet a fully registered practitioner to someone who's a fully registered practitioner. So I was wondering if I could get Prof. Iskandar to share some of the updates from those guidelines and your thoughts about how this will or can possibly affect HIV positive healthcare workers now.
Thanks, Pui Li. I just want to maybe provide, before that, just answer some of Prof. Ong's and Prof. Victor's comments and questions. I think and it also came up on the chat box. I think the reason why there's uncertainty internationally and regionally is because the actual risk of transmission is unknown to your colleagues and yourself. So I think that needs to be asked. And that's exactly what you're asking. What is the actual risk of transmission in the event an infected healthcare worker is continuing to do an exposure-prone procedure? And you can use different scenarios. One scenario is they're on antiretroviral therapy. Another scenario is that they're not on antiretroviral therapy and their viral load is high. Let me just divert away just from occupational transmission and go to sexual transmission, because that's where there's a huge evidence base. Now, based on, and you can't talk about HIV without talking about sex, so I have to throw sex into this, okay? The evidence behind what is known globally, an excess prevention campaign of U equals to U, where if you're undetectable equals to untransmittable. So it's a global campaign. It's pushed by HIV advocates. to try and get people to know globally that if you're on HIV treatment, you continue taking HIV treatment, if the measure of the virus in your blood is undetectable, the risk of transmission is zero. In terms of sexual transmission to your HIV infected partner. So then the question is, if you were to ask me, would I be prepared to have sex with an HIV positive person who is undetectable on treatment and continues to take treatment based on the evidence? Now, the evidence is based on one randomized controlled trial and 3 observational studies. And it amounted to about 125,000 condomless sexual acts, meaning that the sexual acts were without a condom and where the HIV positive partner had an undetectable viral load. So I repeat that, 125,000 sexual acts in serodiscordant couples where one partner is positive, the other partner is negative. In order to enter the study, they had not to use, they needed to not use condoms. And the positive partner was on treatment and had undetectable viral load. And there was 0 linked transmissions in over 125,000 sexual acts. Sorry, I keep on repeating that, but I'm just emphasizing that we have enough data to show this. Now, this is with respect to sexual transmission, okay? And in the setting of an undetectable viral load. Does that apply to occupational transmission? More than likely. We don't have any strong evidence when it comes to occupational exposures, and those trials will probably never be done. But we can safely extrapolate the zero, not just negligible, 0 risk of transmission from sexual transmission to occupational exposures. Now, the risk of getting HIV from a needle stick injury, as I think you mentioned earlier on, is about 0.3%. The risk is less with sex. But it's all extrapolation, but it makes the situation very, very likely. The question also arises, so if I had a needle stick injury from somebody who's HIV positive and has an undetectable viral load, so they're on treatment, they're taking their treatment, they're not missing their pills, and the measure of their virus is undetectable. Would I take post-exposure prophylaxis to prevent HIV infection? The answer would be no. I would be extremely confident that there is no risk of transmission. And so as these evidence emerges, the problem is getting the information to the people that matter, to healthcare workers, to the general public. People feel very dissociated, that HIV infects someone else. It always affects somebody else. It doesn't come to us. It's always, and there's always a moral judgment until you meet the person who has HIV for the first time. And then life changes, because you see the person for what he is, not for the disease that the person has. Now, I can go on about that, but I won't. I'm just here to explain to you the clear risk of transmission, which, in most circumstances, it would be 0. Now, in answer to Pui Li's question, so the MMSE guideline was also updated in response to a lot of discriminatory practices towards healthcare workers with HIV, and not keeping up to date with the latest guideline. As Prof. Ong clearly pointed out, the UK has been a leader in this with more than 10 years of guidance. So in terms of what the guidance say now, and I've be quite specific here. So healthcare workers living with HIV can perform exposure-prone procedures if they fulfill the following criteria. Number 1, if they are on effective antiretroviral therapy. Number 2, if the plasma viral load is undetectable, and by definition, they've used less than 200 copies per mil in the guideline, on 2 occasions, no less than 3 months apart. So there you have your frequency of viral load monitoring, and you have a figure. They must be subject to plasma viral load monitoring every 3 to 6 months, as decided by a Fitness to Practice committee, which is overseen by MMC, and under joint supervision of a responsible physician, which is often an ID physician overlooking their care, and an occupational health physician. So that's where Prof. Victor comes in, from the employment organization. And if the viral load at any point of time goes up, and you mentioned this briefly just now, then they have to cease all exposure-prone procedures until a repeat viral load takes place and more clarity on the risk of transmission. And so it comes into a more evidence-based guideline which protects healthcare workers and in line with the latest guidance. And it goes on to explain what happens to newly diagnosed healthcare workers and who should be responsible for monitoring monitoring the infected healthcare workers. So it's very clear, it's more evidence-based, it's more permissive to allow the healthcare worker to be allowed to work. And it specifically identifies the highest risk exposure-prone procedures in surgery. And it allows it, okay, more importantly, in line with guidelines which are more permissive.
Thank you for explaining that so well. I think that figure is going to stick in our heads, about 125,000 condomless sexual activity. But I think this is where us as a university and a university hospital, we have such a big role to play, because we truly believe in evidence-based practices. All of our research that we do is done to inform how we treat our patients as well. And it's also our duties as doctors and leaders of institutions to ensure that we are able to encourage those who are HIV positive, as well as educate and reassure them should we ever be put in that position. Actually, Prof. Iskandar, there is a question in the Q&A box, and one of the things it mentions is that even if we do have this MMC guidance, is the hospital indemnified from an insurance point of view, I suppose, if a patient were to get HIV from a HIV positive healthcare worker? I'm not sure that you'd be able to weigh in on this.
I mean, insurance and indemnification should also...
Your microphone.
Indemnification and indemnities and insurance should gradually come into this conversation and also take into account evidence-based guidelines. I think the first step is to have MMC backing. That is the first step. And I think that's been a huge positive step in this. And it leads the way for hospitals to follow. Now, I mean, the reality of it is, Prof. Victor, I think if you look back, not just locally, but internationally, how many patients have potentially been infected through occupational exposures by infected healthcare worker? The reality of it is probably, I don't know whether you have that data, the answer to that is probably very, very low. And not only because occupational transmission is low, but nowadays, if we get an infected healthcare worker and they come to us, they almost invariably started on antiretroviral therapy as soon as possible. We don't wait, we just start often immediately. And so really, so that reinforces the even lower number of patients that we expect to be, that we expect to be infected from healthcare workers. So I do think that is a question that we need to ask and address because it's important from a patient perspective. I don't fully know the answer, and I think that can be brought up with the MMC. But you don't expect the number to be in any way high at all.
Thank you for answering that. My next question actually is to Puan Hasimah. After listening to the evidence and the science, and also hearing about what your beliefs are in terms of the direction we need to go in. What are your thoughts about hearing about these updates, and how do you think we can adopt this?
Yeah, thank you, Dr. Pili. I do personally agree that we should adopt these guidelines as well by the Nursing Board of Malaysia. So I'm just being invited by the Nursing Board tomorrow. So maybe we can voice this out that the Nursing Board should as well take these guidelines, because I think we have an increasing trend of the staff, nurses, and also the PPK who are diagnosed with HIV, and we can't afford them to move them out from the clinical area because we have short of nurses. So I think these guidelines as well will be very helpful to nursing.
Yeah, I think that's great. I mean, it's taken us like decades to change our MMC guidance. So I think it'd be really great if the nursing board can get on board with this as well, because then it creates more of a movement and more of a voice of the medical fraternity, guided by science. I was just wondering, you know, do we have any counseling services available for our HIV positive staff?
Yeah, we do have ID nurse counselors in our hospitals for patient as well for staff, because we need to support them in terms of social, psychological, and we need to train and educate all the patients and the nurses or the healthcare worker who are diagnosed with HIV, and also to support them to cope with the medications, adherence, and also to help with adverse effect of the medication. So we have those nurses in clinics and also in wards.
Yeah. Yeah, and I think they also play a very big role in supporting the staff in terms of, you know, confidentiality and helping them through that difficult time, especially within the hospital walls, as you know, stigma and discrimination can be quite rife here. So to Prof. Ong, after Prof. Iskandar's mention about all the evidence about, you know, undetectable equals to untransmissible, how would you feel about advising your colleagues who are HIV positive to continue, and do you think you would discourage any particular types of procedures? We heard a lot about exposure-prone procedures. Do you think it changes?
Right, yeah, thanks a lot. So from what we gathered, I've presented earlier, and also evidence from Prof. Iskandar, it's very clear. The answer is very clear, actually. Yes, you know, it's very clear. It's that the dissemination of the information, the acceptance by the public or even by the medical community, which is all of us here, you know, whether we accept or not ourselves, right? We can, you know, say whatever we want, but inside our heart say, oh, no, jangan, you know, also cannot. But the evidence is very clear. It's yes. If they are viral, it's well controlled, you know, undetectable. The risk is actually zero, like what Iskandar have mentioned. So it's very clear. So that's part number one. Part number two is that, you know, how do we overcome the problem highlighted by Victor? Actually, last week, Ketua Ophthalmology also texted me the same question. I don't know whether she heard from Iskandar or not. Whether her candidate, if got HIV, can come to the Master of Ophthalmology. You know, I don't know why the two questions come at the same time. Iskandar tanya, then Ketua Ophthalmology dengar juga, and then ask me about that. I also say, I don't know, you know, I don't know. So then, because apparently, like what Victor said, they are not given scholarship, penyakit kronik. You know, there was this document say you got penyakit kronik. Thanks lah, you tak payah lah buat master ke apa ke. So that kind of thing we have to overcome. That kind of we need to overcome, and with the evidence that is available lah. So I think you know, this procedure are called there are different category of procedure. I also quote from apa tu up to date my favorite lah, my Google lah. The other category 1, 2, 3. Category 1 minimal risk like endoscopy, apa tu rectal examination, vagina examination. Category 2 possible risk of blood transmission but unlikely, dental, abscess, drainage, biopsy under LA. Category 3 there's a definitive risk like general surgery lah, like what we are practicing lah. So it depends. If the viral load is undetectable, there they said one less than 50 copy per mil. I'm not sure about the figure. What's the figure now?
Yeah, our essay is 20, so 20, we go down to 20,
that's
which is even a lower cutoff point in UMHealth.
All right. So that's very good. So you know, we if they are undetectable HIV, like 50 or 20 per mil, In fact, here up to date said, you can even perform up to category 3 of exposure prone EPP lah. So EPP is acronym EPP. You turn it around become PPE. So it's okay lah. Dia turn it around only. So lastly lah, before and here I just want to it's a lot of WhatsApp group. Thanks for all your encouraging feedback to me. Immediate feedback. Thanks a lot for all the immediate feedback. I just take the liberty to quote Prof Ida, Ketua Jabatan Medicine. Sorry, I quote you dalam your group. Dalam ketua group, Ida said very interesting session. Thanks to all the panelists. Ida said my ENT professor in Glasgow, Glasgow dekat Edinburgh tu kan. I've been there 3 times, I think. Was actually allowed to practice, despite being HIV positive. And that was in the 1990s, 20 years ago they allow him to practice. So I think that is something that we could emulate. Thanks Ida for that input. Thanks a lot.
Hopefully someday one of our Malaysian doctors will be able to step forth and say that as well, that they are HIV positive and they've been allowed to work with the support of everyone. I do have one question, or I think we might need to wrap up soon, but to Prof Victor, I wanted to ask you, what do you think are some of the positive and negative implications for us to adopt or come up with a policy as a hospital for HIV positive healthcare workers?
I think there's only positive implication. There's no negative implication. Basically, being forefront of what we say, what we want to do is important. And I think what we hear today is basically by evidence itself, there's no risk. So it's a similar for any kind of infectious disease. But if the healthcare worker is basically responsible and practicing responsibly and taking their medication and make sure that their viral load is low, there's no risk at all. So we should encourage basically people taking charge of their own life, and we should not we should not be basically taking care of them, but they should take charge of their own life. If they think that they need to be off a certain procedure because they are sick or things like that, then they shouldn't do it. Similarly, that's what we are doing now currently. We are asking you all to take charge of your life, of your health. If you have any symptom, please report it and don't come to work. But we still see a lot of people who basically coming to work with even symptoms. They're talking about COVID-19 now, which is very simple, very similar things that we are facing. People having flu symptom coming to work and infecting other healthcare worker and also patient themselves. And that is basically the responsibility we need to put on to the individual, the healthcare worker. If you are sick, if you have symptom, you have any symptom, not just HIV, but even respiratory symptom, and see whether you should come to work or not, or if you come to work, what precaution you should take. So those are the things. Responsibility, we should give back the responsibility. We shouldn't be just saying whatever policy is good is there, but policy also needs to give them the ability to take charge of their own life, and that is what is important. And we should give back the dignity to all these people, and we should not be saying what you can or cannot do. We tell that this is what you need to do, you should do it. But we cannot say you cannot do this, you cannot do that, you cannot do this, you cannot do that. This is basically it's not the right way forward, and it's coming out from us is worse still. We should not say that. Thank you.
Yeah.
I think one thing which is missing here, which we often have when we discuss issues around HIV, is to have a person living with HIV who is a healthcare worker at this discussion, and it's a pity that we will never be able to get that, because it involves disclosure and breach of confidentiality. But the perspectives from somebody who's a HIV positive healthcare worker will go a long way. One thing also I'd like to add that, I think it's very nice to see the perspectives of Prof Ong and Prof Victor, and so energized. And the ID unit, I'm certainly happy to work with all of you to at least evolve. It at least allows us to change and evolve the narrative, from the current status quo, which is very outdated. So at least this has been very fruitful discussion, and especially from nursing as well.
Thank you. I was just wondering, Prof. Victor, do you think that coming up with a policy like this would be a challenge that our OSHA would want to take up?
I don't think it will be a challenge because we have buy-in from our chief nursing officer already. Okay, our chief surgeon also is buying it. All right. So if the riskiest procedure here is buying in on that, I think we don't have a problem. Of course, OSH itself is basically that's what we want to do. We want to give dignity to the people for them to work. That is what important. Doesn't matter whether you have COVID or you have HIV or you have any other diseases. The dignity should be given back to them. And when you can work, you're contributing to the society. You're contributing to society. You contribute to the country, and we don't have to pay for your what do you call that? We have to compensate you, and that is what we want. We want you to be self dignified. That is what I think is important for us to understand today. It's not about rules, but about you taking your own responsibility. I think that's important, and we agree, and we should do it.
I'm happy to hear that, and really thankful as well that you're all my colleagues here. So we've actually reached the end of our time, but would we have time for Q&A? Yeah, so we do have a few Q&As in the box. I'm going to try to pick some out. We have a question from Adina. Some supervisors or healthcare management officials argue that they need to know so they can allocate low-risk tasks to the healthcare workers. What is your comment on that? I think we might have answered this during the panel discussion, that basically we want them disclosed so that we can help them ensure that they're virally suppressed, and therefore low risk tasks don't come into question. We have a question from Tunku Sara. What is the evidence for transmission from a HIV surgeon to pass on the disease to a patient? If a patient like this doesn't disclose and a patient is infected, can they sue you as the physician in charge for not insisting on disclosure? Do you want to take this question?
Thank you for the question. I think I've sort of also partially covered it. I honestly believe that the risk of transmission, once again, I'll reiterate it, of HIV from HIV positive healthcare worker who is on treatment, continues to take treatment, and maintains an undetectable viral load is zero, even through occupational transmission. Not negligible, but zero. And I've mentioned the reasons why. And so I don't think, I think we just need to be more confident about this and apply to guidelines and policy. I didn't get the second part of the question fully.
So do they have the right to sue? Can they sue you? I think it's what it was.
Yeah. So that question was addressed earlier.
Yeah. So another thing, maybe I'll get Prof. Ong to answer this. So it's a question of whether trainees ask the question of whether they need to test for HIV or whether they have HIV.
Okay, on that part, I don't think is it the requirement to test HIV before you enter master? I don't think it is. It is?
Yes, it is basically you need to do medical checkup, and HIV is one of the tests you need to do.
Is there or is not there?
No, it's there. It's not in the form.
Not in the form.
In the medical checkup.
Right. Okay, so that is the practicality of it, lah.
So basically that shouldn't be there, lah. Because it does not what you call that, implicate on whether you can practice or not. The issue is, we know, I think Prof. Iskandar would basically give more information that it's not about just transmission, it's about ability to perform as a normal human being, ability to contribute to society. I think maybe Prof. Iskandar can say in that way so that people will understand that they are just like you and me.
I mean, by preventing people from what you take skills away from your hospital and from the benefit of the society, which does not make sense, and reallocate them to tasks which are not in accordance with their skills. So I completely support that.
There's a question from Yu Kuen Chan. Do patients have a right to ask or challenge the system if they found out that their practitioner is positive? I guess patients always.
The same thing question. If your healthcare worker is COVID positive, what happens?
But patients definitely have the right to choose their practitioners.
But patient definitely have right to do whatever they want, but if you have the best doctor, best surgeon who is HIV positive, did the best surgery, who do you want? You want the second best surgeon or the best surgeon?
But having said that, I don't think the health status HIV positive negative should be disclosed to anyone.
I agree that it should not be disclosed. I guess if they found out is the question.
The best surgeon, correct.
Otherwise, I think all the patients in my clinic surgery will ask semua, are you positive, negative? Semua pintu kada, Dr. A positive, Dr. B negative. I think it's not practical. Yeah.
Right. Which one? Tunku Sarah has another question. How often should a worker be tested?
According to the MMC guidelines, every 3 to 6 months. And if they don't turn up for the appointments, then they need to be contacted. And if they still don't come, they're then reported to MMC.
And also, I think this is pertaining to the MMC guidance as well from Gan Chin Singh. First, do no harm is the oath that all doctors follow in the practice. Knowing that the transmission risk is extremely low for the HIV-infected doctors to patients. However, who and what system are there to monitor the safety for the patients in addition to the infected healthcare worker own effort? I think you answered this in your question earlier when you were talking about how for kind of government facilities it would be the ID physician and OSH to monitor the healthcare worker, whereas in private healthcare it would be with MMC to monitor the healthcare worker. And I suppose by monitoring the healthcare worker, it indirectly safeguards the patient's well-being. Okay. I think that's most of the questions that we have so far. And so I just want to end today's session. I think it was a fantastic conversation and discussion, and I thank you all for sharing so honestly, and also to find out that we're all on the same page, and hopefully more good things will come of this, to end inequalities and AIDS and to end the pandemic as well. So thank you very much to all of my panelists. Thank you.